Hello, everyone. My name is William Adams, and I'm an assistant professor at the University of North Carolina, Greensboro. And today I'm going to be talking to you all about the proper management and care of exertional heat stroke. Before I get started, I just want to briefly go over some disclosures that I have just to be fully transparent with you all. So those are listed here on the screen if you wanted to take a look at those. However, today I'm going to be talking solely on what is published in current scientific and medical literature. There shouldn't be any apparent biases there, since we're going to be strictly looking at what is available in science and medicine. Before we get fully started, I do want to just briefly go over and provide a quick overview of the physiological response to exercise in the heat. And I think this is going to be really good for you all to get a good understanding of what happens to the body during exercise in a hot environment. And then that really is going to be a nice introduction into what we're going to talk about today with exertional heat stroke. So as we exercise, particularly in a hot environment, our body is exposed to thermal stress. Now, to handle that thermal stress, our body has a series of autonomic and behavioral responses to mitigate that heat stress or heat strain, if you will, and to protect the body. So from an autonomic perspective, those processes are regulated from the brain. And what happens is we have a number of things that occur. We have an onset of sweating. We're just going to get into that into the next slide. So we have an onset of sweating to help with heat dissipation. We have vasodilation, so we have a dilation of our blood vessels, particularly in our periphery, so our extremities and our skin. And that is meant to drive blood flow to the skin to help with some of our heat loss mechanisms that we have. Now, from a behavioral perspective, we do have some other things that we will typically do as humans to help offset some of that heat strain. And this could be things such as shedding clothing, particularly if we're wearing more clothing than we need at that time, seeking shade, or to exhibit a splaying posture where you're just kind of spread out and really trying to maximize the surface area that your body's exposing to the environment to, again, aid in heat dissipation. Now, if we take a step forward and look at some of these biophysical aspects of heat dissipation and really how our body gains and loses heat, we have this here, and this is kind of the next step from what we discussed previously when I talked about the vasodilation of the periphery and the onset of sweating for heat dissipation. This is where that comes into play from a biophysical perspective. So on the bottom of this slide, you see this equation, S equals M minus W, plus or minus E, R, C, and K. And this is our heat balance equation. So S in this equation is dictating our heat storage, how much body heat we are storing within our body, okay? Now, the M minus W, the part in parentheses, that is just the part of the equation depicting metabolic heat production. So as we exercise, our bodies need glucose. It needs energy to be able to perform that event, whatever it may be. It may be running, as depicted here. It could be rowing. It could be playing soccer, whatever. So as we are exercising and we are using energy, we break down glucose. However, our bodies are really bad at utilizing all of that energy, where our bodies only utilize 15 to maybe 20% of that energy to perform actual work. So to perform the work of our muscles actively moving through whatever medium we are moving through. The rest of that energy that is broken down is given off in the form of heat. And this is a direct linear relationship to intensity. So the harder we exercise, the faster the rate of metabolic heat production, or the faster the rise in temperature within our bodies. Now, we need to be able to get rid of this body heat that's being produced. Otherwise, we have catastrophic outcomes that occur, which are a bad thing. And that's where we come into the rest of the equation. So if we will disregard E right now, if we look at R is radiation, C is convection, and K is conduction. Okay, and if we start with conduction, and by definition, conduction is the transfer of heat between contact of two solid masses. So in this figure, it's depicting the person's foot coming into contact with the ground, or another example is, placing your hand on a granite countertop, for example. You may feel that countertop or something may be cooler, but the conductive properties that will occur will be transferring heat from your body to that countertop. Your body temperature is going to be much more elevated than that countertop, especially if it's just ambient conditions. So your body is going to transmit heat to that countertop. So for example, say you leave your hand on a countertop for a lengthy period of time. Well, that countertop is going to heat up. So if you take your hand away and then go back and feel different parts of the countertop, you're going to feel some differences in temperature because your body is giving that countertop heat. Okay, so that's what it's like in this figure. Now, during exercise, conduction plays a very small role, if any, in transferring heat to and from the environment, because in most contexts, in most sports, we're not doing much to come in direct contact with a solid mass. Now, there are some examples that we can talk about, but for the most part, in this picture, running, that person's body is not coming into direct contact with another solid mass that has heat. Now, we can make an argument with the shoes, etc., but it's a very small amount compared to the body as a whole. Now, with convection by definition is a transfer of heat across using the movement of air or water. So in this case, as air or wind goes over the skin surface, that wind is going to be drawing heat from the skin surface into the environment to get rid of body heat. Radiation is just that. It's coming from the sun. So this could be directly from the sun, or it could be reflected from another surface, in this case, an asphalt road, to gain or lose body heat. Now, these three mechanisms are considered dry heat loss or dry heat gain. And it's really dictated by the environmental conditions. So if the environmental conditions are hotter than our skin temperature, and typically during exercise, our skin temperature is going to be right around 93 degrees Fahrenheit or so, our body's going to gain heat from the environment. Again, heat's going to go from hot to cold. That's the route of transfer. So if the temperatures are exceeding our skin temperature, we're going to gain heat from the environment, versus if it's colder than our skin temperature, we're going to be losing heat from the environment. So that, when it's cooler outside, we have an added benefit there. From evaporation, this is where we get into a situation, particularly when the environmental conditions are a lot hotter than our skin temperature. And in those situations, evaporation of sweat from the skin surface is going to be our body's only way that we can dissipate body heat from the environment. And there's actually the act of full evaporation of a droplet of sweat. Now, with sweat dripping off the skin onto the ground, we're not doing anything from that perspective. We're not going to be losing any heat because we need the actual act of evaporation from the skin surface. Now, if we just quickly look at the classification of exertional heat illnesses, we kind of have this term exertional heat illness, and this is, I call the umbrella term. And if you actually look at the ICD-10 coding, code T67, this is going to be our heat illness or our medical conditions that are related to heat exposure. Okay. Now within there are various numbers, various subsets of other medical conditions, and our primary four, particularly in exercising situations, are going to be heat syncope, exercise-associated muscle cramps, which at one time were called heat cramps, heat exhaustion, and exertional heat stroke. Okay. Now I might use exertional heat illness and exertional heat stroke. I might use that interchangeably later on. But I want you to get an understanding that exertional heat illness is really just an umbrella term that defines a subset of medical conditions that have different etiology, different pathophysiology, and really different ways that or approaches that we need to take as clinicians to properly manage those conditions. For the purpose of today's presentation, I'm going to focus primarily and only on exertional heat stroke, because this is going to be our only medical condition within our exertional heat illness realm that can cause death if not treated properly and managed appropriately. So where does this typically occur? And for the next few slides, I'm going to talk about where this occurs, look at some epidemiology, we're going to talk about some risk factors, and then we're going to get into our management and care of this condition. So bear with me, and we'll try to get through this so we can get into the more meat of the presentation as far as how you as a clinician can properly manage this condition, ensure that your patient's going to survive. So where does exertional heat stroke typically occur? Well, I have these 4 settings here, and if we look at in situations with exercise or physical activity, this is where we're going to be seeing most of our exertional heat stroke cases. We have our traditional athletics setting, we have occupational settings. So, this picture depicting railroad workers, but this could be construction work, roofing, paving. It could be in a steel mill, coal mine, etc. So, any occupational work where the occupational workers are exposed to potentially extreme environments or required to wear protective equipment, etc. We also have our military settings, again, from similar reasons as occupational, requiring the use of protective equipment, clothing, potentially being in extreme environments, etc. And lastly, our mass participation events. And this picture is depicting the Falmouth Road Race. And I'm going to come back a few times to this particular road race just because it's a unique race. And we see a ton of exertional heat stroke cases at this particular race. And this is a really good example to kind of bring back some of the other components of this talk to provide a real world example for you all. So from an exertional heat stroke perspective, if we look in the news on a yearly basis, we're oftentimes plagued with stories of young kids succumbing to exertional heat stroke and dying. And most recently, we have the exertional heat stroke of Jordan McNair from the University of Maryland, and then Braden Bradford, community college student in Kansas, originally from New Jersey. Both of these individuals died from exertional heat stroke. And the ensuing reports that have been made available have identified a number of lapses in care or a lapse in the proper recognition, management, and care of these individuals and these patients to ensure their survival and thus resulting in their death. I showed a picture here of the one from the University of Maryland. There has been a follow-up with the Braden's case there, and I would encourage you all to go and access those. Those are open access, free to the public, and they provide a really thorough overview of the events in those given days and allow you to kind of critically appraise that on your own. So if you look at heat illness and exertional heat stroke rates in the various settings we just discussed, we're going to start with athletics. And this is going to be primarily what we're going to focus on mainly just because, this is where we as clinicians, as athletic trainers, are typically going to be spending most of our time, or we're working in the traditional sense. So this is a depiction of where exertional heat illnesses are occurring in athletics. And this is focused specifically at the secondary school level. And this was work done by Yard and Zach Kerr. And you can see that exertional heat illnesses are occurring in every and any sport at the secondary school level. But you can see that there are some differences based on the sport itself. And we can see that boys American football is going to have the highest incidence rate compared to the other sports. Now, this makes sense based on when American football begins in the United States. It begins in August. And what they're asked to do. They're asked to perform, very short, high-intensity bouts of exercise while wearing protective equipment. And that's the big key here, the protective equipment piece. And that protective equipment is going to be covering roughly 3/4 of someone's body. So if we go back to our biophysical aspects of heat loss, that protective equipment is going to be impeding the body's ability from getting rid of some of that metabolic heat production, thus increasing the risk of exertional heat illness. But again, know that heat illness and exertional heat stroke can occur in any sport. Now, if you want to look at geographically where these are occurring, we can see based on this figure that most of these exertional heat stroke cases, and in this case, this is a 30-year review of heat stroke deaths in American football in the United States. And we can see that most of these deaths have occurred in the southeast part of the United States. Again, going back to where these are occurring. These are occurring in American football, which starts in the end of August. In the southeast part of the United States, it gets, it's very hot and very humid, which increases the risk profile. But again, notice that these are occurring in other places and in other states where it may be, a little cooler, than others. So think of, the temperatures and conditions in Minnesota versus that of Georgia and Florida. Vastly different based on geographical longitude and latitude, but we still have those occurring. Now, if we look at the number of deaths and if we expand our data profile out a little bit further, and again, we're sticking solely with collegiate and high school football, we can see that the number of deaths that have occurred in 5-year blocks have varied over the past 40 plus years. And we could talk for hours about why this may be and everything, but if we just look at this graph and if we draw a line, we can see that, for the most part, there's an upward trend in the number of patients or number of individuals that are dying from exertional heat stroke, which to me is troubling because as we have progressed and as medicine has evolved to knowing how to properly manage this condition, there shouldn't be anyone that dies from exertional heat stroke in sport, but yet we're seeing more people die. So that's just problematic in and of itself. And again, we could probably spend a full hour to 2 hours talking about just this one slide and factors that have led to this increasing trend. The point I want to make here is, we know more of how to keep people alive from this condition, but yet we're seeing more people die from this condition. So just keep that in mind as we go forward. Now, if we transition to the military setting, here's a graph looking at a 9-year period of the total number of heat stroke and heat exhaustion cases in the 4 branches. Now, I know the Coast Guard is included here, and I do not include them, but our 4 primary branches of our military, we can see where those trends are. And, the Army having more cases than the other branches, which makes sense based on the overall size. Again, going back to the population size, but we can see the number of cases that are occurring on a yearly basis that are reported. Now, from the same data set, I went forward and made another graph where I wanted to look specifically at the different parts and different aspects of the military. And I wanted to look at those who were recruits, enlisted, or officers. And the difference between the recruits and the enlisted is really just their ranking. So those who are ranked E1 to E4, those were defined in this data set as our recruits, as those are the individuals that are going through the basic or their initial phases of training, basic training, and the other job-specific training after that. Those are defined as recruits. The enlisted are E5 to E9, and then our officers. Now, based on the left-hand side of the vertical axis for each of these 2 graphs, these are just the total numbers. So how many cases are occurring? And this is going to align with our previous slide with the total number of cases that have occurred in these areas. Now, the axis on the right-hand vertical axis, this is looking at incidence rate. And this is where I think is really unique, because if we actually look at the incidence rates between the different classifications, we can see that the incidence rate of our recruits is much higher than our enlisted and our officers, which I think is really intriguing. And I'm going to show some data later on as far as why that may be. But, if we think of our recruits, these are the ones that may be coming right from high school or from other situations. They may not be accustomed to the demands of the military and military training. They may be from different parts of the country. So someone may be from Maine and they may be reporting to Parris Island in South Carolina for basic training for the Marine Corps. So a vast difference in geographic locations. So this can come into play as far as why these risk profiles may change. But I think this is really unique and why I wanted to show that for you all. Now, if we look at our last setting, our mass participation events, and again, I'm bringing back the Falmouth Road Race, and just a little bit more information for you all, for those who are unfamiliar. The Falmouth Road Race is a 7-mile road race in Cape Cod in Falmouth, Massachusetts, that occurs the 3rd weekend in August. Okay, now you might be thinking, oh, Cape Cod, Massachusetts, it's going to be a nice ocean breeze, which there is. It's not that hot compared to, say, North Carolina or Georgia, et cetera, which is true. You know, it's a little cooler than that. However, it's very unique because it is the end of August, and oftentimes it is rather humid. It can be warm. It might not be warm as far as what we are exposed to living down here in this part of the country, but it may be warmer for those who are residing up in New England or other parts of the country or world. Um, so this graph here is depicting the number of heat stroke cases that were treated at this race dating back to 2002. And we can see that these rates vary across time, and we can have some as low as 8 heat strokes, as shown in 2010, or as high as 48 to 52 that were observed in 2015 and 2003. Now, from the 2015 race, just to provide some context, since I was there at this race providing medical care to the patients, at 7 a.m. that morning, there was 100% humidity. I mean, it had rained the night before. It was extremely humid, extremely muggy. And although the temperature didn't get that hot, still the upper 70s, almost 80 degrees Fahrenheit, and extremely humid conditions kind of created a situation where, you know, we had a lot of cases coming in. So as we transition into looking at factors affecting thermoregulation, we've talked a little bit about where these are occurring. Now let's talk about why these occur. And if we look at factors that are influencing thermoregulation, here's 9 factors that I just came up with. Now there are a ton of more. There are a lot more examples. There are a lot more things that we can throw into here. But these are the primary ones that one would think of when we're thinking about risk of exertional heat stroke and whatnot. So this table here was published in 2004, and what this table, or what this study examined was, they wanted to look at a case series of 6 fatal incidents of exertional heat stroke, and then they want to compare that to some non-fatal cases that are depicted on the right-hand side of this figure. But what I want you to pay attention to is the left-hand column, which is the predisposing factors. So these are the factors that, following the events that led to the investigators to say, you know, these are one of the things that led to this person's or this individual's exertional heat stroke. And if we look at the figures or the table here, and each of the numbers across the top kind of column, those are indicating each of the 6 individuals that had succumbed to this injury and passed away. And the point here I want to hopefully get across to you all is there are a number of risk factors that are involved with exertional heat stroke, but it's very individualized as far as which factor is going to be present at the time of the exertional heat stroke. So for this case, only 2 out of the 6 were shown to be dehydrated at the time of their collapse and death. Now, if we look at their improper acclimatization, so they weren't used to exercising in those environments, you know, 4 out of the 6, it was indicated that that was a positive event there. Now, if we go back down and look further at organizational factors, which, you know, kind of make more sense from, you know, both the military and the athletics perspective, we can show that all 6 of these individuals were exerting themselves at a level that was well above their own physical capabilities. So, you know, think of the military setting where someone's asked to do a certain task at a certain intensity, and they may not be physically capable of doing so based on their fitness level. Or the same, you know, with an athletic setting as well. And that's a big factor here. If you're forcing someone to exert themselves over and above what they're capable of doing, we can have some, you know, problems down the road, particularly if it's hot outside. And lastly, this isn't necessarily a risk factor, but this is going to factor into the rest of our talk in the absence of proper medical triage. So in this case, you know, these soldiers were not properly triaged, which meant that they weren't able to be properly treated based on their condition that they had, which led to their deaths. So, you know, this is, you know, a good kind of segue going forward, but we're going to get back to this. We actually want to look at some data looking at these risk factors and how they influence thermoregulation. I'm going to focus on these three here just to keep this short, because again, we could probably have a whole nother lecture on these risk factors and how they predispose one to illness. But we're going to quickly go over these three factors here. So if you start with hydration status, this is going to be one of the factors that we're going to talk about. And you know, as we are living day to day, you know, 50 to 70% of our bodies are made up of water. So water is going to be an essential component for life. And without water, we as humans will perish. We cannot sustain long periods of time without water. Now, our bodies do a really good job of maintaining water balance, and you know that is done by a number of factors. But if we look at an exercising situation, for example, say we're exercising, it's hot outside, and say it's hot outside. Well, we're going to need to sweat in order to have the evaporation of the sweat from the skin surface to help maintain homeostasis of our body temperature to prevent it from getting to catastrophic levels. But as we sweat, we're going to be losing body water. And as we lose body water, we're going to be losing body water from both within our cells as well as outside of our cells, and primarily within our vascular system. So to kind of think forward and discuss how hydration affects temperature regulation. Say we are getting dehydrated, we're losing body water, and as we lose body water, our body goes into protective mode. So if we're exercising and we're getting dehydrated, to help maintain central pressure within our bodies and some other key regulatory factors that our bodies need to survive, our bodies are going to adapt. So as we're getting more dehydrated, our sweat rate is going to decrease. The amount of sweat we're producing is going to decrease. And if we're decreasing our sweating rate and we're decreasing the ability for that to evaporate off the skin surface, we are decreasing the evaporative heat dissipation that can occur. So it can increase our total heat storage from that perspective. So if we look at our data here, this is a 6-hour march, and this was done back in 1944. So this was done a long time ago. And part of the reason I wanted to show this is we've known this for a very, very long time. So this isn't novel, this isn't new. In science and medicine, we've known this for a long time. So in this study here, they tracked rectal temperature throughout a 6-hour march, and you can see kind of the intensity. It was 2.5% grade at 3.5 miles an hour, so it wasn't too hard. It was a nice walk. And they had some rest built in, but they had 3 different conditions, where the bottom condition, which is the dotted slash line there, those are the conditions in which the participants consumed water at the rate that they were sweating, so they matched their sweat losses. The middle set of lines, which are the more dashed lines, that's ad libitum, so people consume water whenever they felt that they needed water. This is really driven off of the sensation of thirst. And the solid line is depicting the condition to which they received no water. And you can see in that condition that they exceeded this threshold, this rectal temperature threshold of 102 that the researchers had put in place really early in the march. Now, if we fast forward about 50 years or so, we still see the same trend. And this is a much more controlled study. And they looked at the difference in esophageal temperature and body temperature just during 30 minutes of exercise. And they found that those who were significantly more dehydrated at 1.5 and 3 and 4%, those were statistically different and significantly higher than those who were normally hydrated. Again, showing that dehydration does play a big factor into our body's ability to get rid of body heat. If we look at heat acclimatization, and this is just a fancy term that depicts one's ability to tolerate a thermal load or heat stress during exercise. This is a process that really allows your body to adapt and develop some responses that help the body exercise in a hot environment. So that's depicted here. So we can see along the x-axis from the days of heat acclimation, and typically in acclimatization and acclimation protocol is going to be 10 to 14 days in length. And we're going to talk about that in a minute. But you can see that there are a number of adaptations that occur. We have some cardiovascular adaptations that occur. So we have a reduction in exercising heart rate. We have an expansion of our plasma volume. We have some thermoregulatory adaptations that occur. So we have a reduction in our body temperature. We have a reduction in our skin temperature to help with that thermal gradient to get rid of body heat at a much greater rate. And we have an increase in our sweat rate, which helps again with our evaporative heat losses. Now, the reason why we typically say that the acclimatization process takes 10 to 14 days is because some of the fluid balance and fluid regulatory adaptations don't occur until a little bit later on in this process, and we want to make sure that we are capturing all of that. And at 14 days, evidence suggests that about 95% of our adaptations have been acquired at that period of time. So if we go and have an acclimatization protocol that's 14 days in length, we can pretty much be ensured that 95% of all the adaptations that will occur have occurred, okay? But what does this process look like from an organized athletics setting? Well, this figure here is going to show just that. So this table is going to be depicting both the process at the collegiate as well as the secondary school level. And these processes are typically, they're relatively similar. And basically what these processes are dictating are, they're dictating the length of practice or training, and they're dictating when certain protective equipment can be worn. So you can see in the NCAA level on the left-hand side, we have our practice considerations that, you know, for the first 5 days, nothing can be more than 5 hours, or no, sorry, my apologies, nothing more than 3 hours. There can be a walkthrough that's an hour in length, but there has to be 3 hours between the walkthrough and the practice. And whatnot. And we see how the phasing of equipment occurs, where days 1 and 2 are helmets only, 3 and 4 are helmets and shoulder pads, and starting day 5, collegiate football players should start wearing full pads. Now, this process is really similar to that at the secondary school level, as you can see. However, there are a little bit different, a few differences. One being that the helmet shoulder pad length is 1 extra day, so it's days 3 through 5. And that's just a little bit more conservative of a time frame. In addition, at the secondary school level, 2-day practices are permitted, but not until day 6, and those have to be separated by a single-day practice in between there. And the difference between the college and the high school level occurred a couple of years ago, where colleges got rid of 2-day practices, and this was really primarily in response to the repetitive head trauma and the concussion risk and long-term implications from that. So that's why in college football, there are no more 2 days permitted. But at the secondary school level, those are still permitted for now. Well, the question that we have to ask ourselves is this process, having a heat acclimatization process where we phase in equipment and how long practice could be and when practice could be, is that effective? And is that going to be protective for our student athletes? Well, we published a study last year. We wanted to look just like that. So we looked at the 7 states in the US that had required their secondary schools at the state level to abide by the recommendations outlined in the previous slide. So there, at the time when we did the study, there were 7 states that said, hey, every high school in my state that's a member of our athletics association has to follow these regulations for heat acclimatization. So what we did was we looked at heat illness rates before that rule change was made and after, and we wanted to compare, hey, was this effective? And what we found was we found a IRR of 0.45. And for those who aren't familiar with what that is, with our incidence rate ratio, we can flip that around and show that, hey, if we do this, and for the states that did this, they found a 55% reduction in the number of EHI cases in those states following the rule change. And this is a pretty large number that, we are effectively mitigating a large percentage of heat illness rates, but just by instituting a rule that tells coaches, when they can practice, how long they can practice, and when they can let their athletes wear pads. So really, aside from printing on a piece of paper or the time spent to email it out to the administrators and coaches, this costs no money. You're just telling coaches when they can practice and for how long. So this is a pretty effective policy for reducing the risk of heel illness. Now, if we look at our environmental conditions and environmental temperatures, here's a study we did, and this is data from the Falmouth Road Race. The graph on the right is showing increasing environmental conditions measured by wet bulb lobe temperature. So the environmental conditions on the x-axis getting more extreme. And we can see the different trends in our data, looking at our exertional heat stroke rate, our heat exhaustion rate, and some combined data. And what I want for you all to recognize is that as the environmental conditions became more extreme, we had a linear rise in our incidence of exertional heat stroke, which makes sense. The hotter it gets, the more stress on our body, and the harder it is to dissipate that body heat. Now, the graph on the left-hand axis is just the same data superimposed using a flag system. And for those who have flag systems in their own states, such as that here in North Carolina, that's what it is. Green being lowest risk, black being highest risk, and in here, in North Carolina, it's canceling of those events or rescheduling those events. And we see that, hey, as the stress level, as the risk levels increased, our overall incidence rate increased as well. So now that we're through that first half of the talk, I want to spend the rest of the time here talking about how can we make sure that our patients stay alive if they succumb to exertional heat stroke. And what I want you to kind of keep in the back of your mind is that while exertional heat stroke is not 100% preventable, exertional heat strokes are going to occur, and they're going to continue to occur in society. So we can't prevent everything. We can do our best to mitigate risk, but we can't 100% prevent something from occurring, especially in this case with exertional heat stroke. However, if the exertional heat stroke does occur with proper management and care, we do have a 100% survival rate of these particular individuals. Now, the rest of this talk is to be structured and outlined based on this document here. And we had a meeting a few years ago where we brought together athletic trainers, emergency room physicians, sports medicine physicians, military physicians to a meeting to develop a consensus statement on the pre-hospital care of exertional heat stroke and how to best care for heat stroke patients when we're incorporating other aspects of the medical care system. And within this document, we came up with 4 steps for survival. We have rapid recognition, rapid assessment, rapid cooling, and rapid advanced care. And that's what we're going to focus on for the rest of this talk is break the process down to these 4 steps. And I'm hoping at the end of the talk, you're going to all be able to see that if we have a breakdown in any of these 1 steps, we can have a catastrophic outcome. So in order to ensure our 100% survival from exertional heat stroke, each and every one of these 4 steps needs to be in place to going forward. So let's start with rapid recognition. And what does this look like? Well, this is, just looking at the simple fact of, hey, we are observing that there's an issue. Now, this could be in a number of settings, right? So if we're in an athletic setting and we're on the sideline of football practice, that may be noticing one of our, football players struggling through, say, end of practice conditioning, and it's really hot outside and they're kind of stumbling around or they collapse. Obviously, that's an issue. They shouldn't collapse in a normal situation. So, that would be that. So in this case here, this is from the Falmouth Road Race. And this is one of our elite runners that had to come into the race that was having issues. Now, to provide some more details as far as why this is a unique situation in itself, the Falmouth Road Race garners international attention, where we have runners at the very elite of elite levels coming to run this race because the prize purse for the overall male and female winner is quite extensive. And if you win the race and in everything, and you're the overall male or female winner, you go home a lot a lot richer than you were before that. Particularly in the fact that our normal finishes times for this race are anywhere between 32 to 37 minutes between the males and females. So again, going home with a large sum of money for only exercising for about a little over 30 minutes is really enticing. So when we have an elite level runner that has come in, that's problematic because these runners, their occupation is to train, is to run, is to compete. So their bodies are fine-tuned machines when it comes to this. So having this situation come in, having an elite runner come in is obviously problematic. And this individual was probably spotted as soon as they finished by one of the medical volunteers by the finish line. But how do we recognize an exertional heat stroke? Well, if we go to our most current position statement by the NATA, we have two ruling considerations. We have excessive hyperthermia, and we have CNS dysfunction or ultramental status, which can be anything from someone being confused, or they could be disoriented, they could be irritable, they could be exhibiting aggressive behavior, or they could be unconscious, okay? And I do want to go ahead and state that the absence of ultramental status does not rule out exertional heat stroke, especially because there's a lucid interval that may exist. And a perfect example, back in 2011, a good friend of mine, Dr. Rob Huggins, and I were volunteering at the Boston Marathon. And he had a runner that had come to that was brought to his section that he was assigned. Rob did an initial evaluation as far as, hey, what's your name, where are you from, what's your finish time, just getting just some basic questions to see, what was going on. And the runner, expressing that they just felt tired and really worn out from the race, which makes sense because they just ran, 26.2 miles. And this particular runner had run it in under 3 hours, which is a pretty good marathoner. So Rob had given him a bottle of water, said, hey, I'll come back around in a couple of minutes and checking on you after I check in with some of the patients in my section. A few minutes later, Rob kind of looks over and the individual is on the end of the cot trying to unscrew the cap off the bottle of water. However, the bottle of water was given to him without a cap on. So right there, that was kind of an indicator, yeah, that's not right. Like the cap isn't even on there and he's trying to unscrew it. So Rob goes back over, asks him a bunch of the same questions, doesn't know anything, and then they go on and assess his temperature and treat him for heat stroke, and he survives. But again, the point here is someone may appear lucid, they may be able to respond initially, but they will quickly deteriorate, and that's what I meant. That's what I mean here by there might be a post-lucid interval, but they will deteriorate very quickly. So, once we notice that there is an issue, so we have a patient or an athlete or someone struggling with a task they're required to do and it's hot outside, and exertional heat stroke may become one of our differential diagnoses, how do we rapidly assess that condition? And I want to throw this figure up here, or this table, because this is a really good transition between our previous discussion of recognition and our assessment. So along the vertical axis, we have a series of signs and or symptoms going from CNS dysfunction to dizziness to core body temperature to other things there. Across the horizontal axis on the top, we have a number of medical conditions. The first four being our exertional heat illnesses that we talked about very briefly before. And then we have some other medical conditions that could be catastrophic. However, each of those being treated differently. And if we look back at our recognition where we need to observe ultramental status, we can see that a large number of the conditions that are listed here all potentially exhibit with ultramental status. So just going off of CNS dysfunction by itself is not very good and not very conducive to us as clinicians in dictating the proper course of treatment for this particular case. And if we actually look at exertional heat stroke, that's the only condition where we have a extreme hyperthermia and CNS dysfunction. So if we are able to observe ultramental status, and if we're able to rule out other conditions that are going to kill someone faster than heat stroke, so in this case, respiratory or cardiac arrest, we need to have an accurate assessment of body temperature. Well, what are our options for body temperature? How do we accurately assess body temperature in an exercising individual? And this is kind of where we get into this situation where we need something that's feasible for the setting that we're in and valid. So here's a list of just some common types of, or common sites for temperature regulation or temperature assessment where we can assess temperature. Now, in an exercise situation, rectal temperature is going to be not only our most valid, but our most feasible assessment of internal body temperature. So if we actually just think about the validity piece for a second here, and if we want to say what's a valid assessment of temperature, we can actually look at our bottom three on this list: the ingestible thermistor, the esophageal temperature, and our rectal temperature. All of those are valid assessments of internal body temperature during exercise. The first five are not, because think about what happens during exercise. As we exercise, we start sweating. And if the environmental conditions are a little bit cooler than our skin, for example, that's going to cool down the temperature of the sweat that's on the skin. And depending on the person's sweat rate, etc., we can really have a thrown off sample if we're trying to assess body temperature that way. Because the other five assessments above are going to be assessing temperature externally at our periphery, at our skin. Now, from a feasibility perspective, the top five may be feasible because they might be easy to assess, but then we lack the validity, so it's useless. It's junk for us. But if we look at our bottom three that are valid, the feasibility piece comes into play here. Now, the ingestible thermistor, these are a good way to track someone from a preventive perspective. They swallow a pill, a radio frequency pill, 6 to 8 hours prior to activity. It can monitor body temperature throughout practice, for example. However, you're limited to the fact that they have to swallow that 6 to 8 hours before activity. To ensure there's no influence of water entering their stomach. And you have to worry about the risk of the thermistor not working. The battery might be dead, or the radio frequency may not be working properly, or they may pass that thermistor before they get to that practice. The esophageal temperature, although valid, is not feasible, particularly if someone has an exertional heat stroke and they're, say, combative or irritable, because a method of assessing that is to shove or is to place a flexible probe in their nose and down their throat, to a level behind their heart, so about 40 centimeters. And someone who's combative there's no way that they're going to let you shove something down their throat, in their nose and down their throat. So in this case, the rectal temperature becomes our best option. And this has been shown a number of times, and here are some more recent examples from both the lab as well as a field-based study comparing different devices and body temperature. So for the next couple of slides, we're going to show some results from those studies and some other studies. For the next two slides, the x-axis is going to be depicting time, so exercise time, and then the y-axis is looking at body temperature. The dark blue line, that's a little bit more bolded. For the next two slides is going to be our rectal temperature response. And the other lines will be the other measures that were being analyzed in this particular study. So we can see as exercise started, rectal temperature increased, it kind of stayed steady. And then at the point of when exercise stopped, right before you see that start on that sharp decline, we can see the recovery period there. And for this comparison, oral thermometry was examined, and this was looking at a Welch Allen thermometer, so the nice $300 monitors you can buy and the ones you see in a clinic, or pretty much every clinic. That was that thermometer, and then a nice cheap $10 oral thermometer from Walgreens was compared. And you can see that as one exercise, there was no change in those two oral thermometer measures. So it wasn't close to being able to accurately depict the rectal temperature response in this figure as well. The same response was shown when looking at the temporal temperature assessment response. And in this case, this is actually more alarming to me, because if someone exercised, the temporal measure said that they're actually getting colder instead of heating up. So that should be alarming for all of you, that's not right. And from a tympanic perspective, so inside the ear, this graph is showing that as someone's rectal temperature got hotter, the difference between the rectal measure and the tympanic measure got bigger. Which again should be alarming because it's not accurately tracking those measures at all. Go back to our example I just talked about with the Boston Marathon. When the patient started to deteriorate, and Rob, was assessing the individual, he had mentioned to the physician in that section, "Hey, we should get a rectal temperature on this the patient." The physician's like, "Oh, we'll just take a tympanic measure. That should be sufficient." But in disagreement, Rob had retrieved both measures, took his tympanic measure, which measured 98.6, and then took his rectal temperature, which measured 106.8. So an 8-degree difference in just these two sites, which then prompted the individual's treatment and then survival from that condition. But we need to ask ourselves some questions. Why do we need an accurate temperature? Why do we need something that's both valid and feasible? Well, we need to determine if there was an exertional heat stroke or not. Because the course of treatment is going to be different. Going back to our table before, there's a large number of conditions that may exhibit CNS dysfunction, but we need to know what we're dealing with so we can properly treat it, right? So if it's not an exertional heat stroke, what is it? Is it heat exhaustion? Is it a head injury? Is it a hyponatremia? Is it a glucose issue? Is it something else? We need to determine when to stop cooling, which we're going to talk about in our next section with cooling. And then lastly, we need to be able to determine if the heat stroke actually occurred. And this is going to really dictate our recovery and rehabilitation plans, which I'll talk about toward the end of the presentation. So questions I always get are the feasibility and really the privacy aspect. And this series of figures I compiled in a recent text that I had published to show really how easy it is to assess rectal temperature and to maintain the patient's privacy. So as we can kind of go from figure A to F, we can see that we can position the patient on their side, we can flex their top leg to access the area that we need to assess the temperature. We can drape the patient with towels and or a sheet, and then the athletic trainer, the licensed provider can go in behind the patient and also in that case block the patient, and especially if there's anyone behind the patient, they can use their body as a barrier. They can assess the rectal temperature quite easily. Once that's assessed, they can pull their clothing or their shorts back up to avoid privacy. Again, this is a really easy process, and with proper coordination with the other people on site, whether it be other providers or your coaches, etc., the patient can be draped easily to take this measure and to avoid exposure from a privacy perspective. Here's just another example from the Falmouth Road Race. On the left showing kind of the instruction before the race itself and everything for the volunteers. On the picture on the right with a nurse actually assessing rectal temperature, and both you and I, we can't see anything because that patient is being draped properly. Again, we can do our best to minimize privacy, and we don't need to do something that's out in the open. If we go to our next steps of survival, our rapid cooling, say we recognize that there's an issue, we see someone not doing well, we suspect it might be exertional heat stroke, and that's within our list of differentials. And in our initial observation and evaluation, we're able to rule out other conditions that are more more timely, such as cardiac and respiratory arrest. And we take a temperature, they're extremely hyperthermic, and we have a case of exertional heat stroke. What do we do next, and how do we properly treat that to ensure survival? Well, this is our mantra, and I want you all to remember this mantra, and this is going to be one of the big things that you need to know going forward as you not only practice this, but to develop your policy procedures and talk with EMS and have your EAP in place, etc. But I want you to kind of take a look at this quote, and we're going to talk about this a little bit more, where it's not the overall temperature achieved. So it doesn't matter how hot someone gets. It's a matter of how long that person is hyperthermic. And that's the real big thing about this particular quote. And really with exertional heat stroke treatment, our goal is to cool someone down within 30 minutes, and this is our golden half hour. If we can cool someone down within 30 minutes of their collapse, and based on the evidence that we have at our disposal, both within published scientific literature and anecdotal events, we know that we can ensure survival, and in most cases without any long-term effects, if we can abide by this 30-minute window here. And this is a perfect example of that. Now, this is not in humans. This is in a rat model because it's not ethical to give someone heat stroke and have them wait until you cool them. There won't be an ethics committee in the world that will ever approve such a protocol. So this is the closest that we can get to that. But we can see here that as someone, or in this case, as the rats were hyperthermic, and the degree minutes is really just in reference to how long that they are hyperthermic. We can see that their survival rate declined quite rapidly. And in this case, their survival rate declined and it was down 50% by that 30-minute window. Luckily, in the human models that we have access to from our observational work, we know that the 30-minute window is sufficient, and we have 100% survival from this perspective. Now, the key to cooling is to cool on site and to cool immediately before they are transported. That's going to be ideal for a number of scenarios. One is just the time, I'm going to talk about in a second, but really the access to proper cooling modalities, which we'll also talk about here in a few slides. But as we're doing our initial evaluation and deciding what we want to do to treat that patient, we have this 600 ticks. We really have a good 10 minutes to evaluate, to assess, to properly diagnose the condition, and then to outline what course of treatment we're going to take going forward. Now let's look at the alternative scenario where we're not going to treat on site. And what would happen if we called EMS? So if we say we have a patient collapse and we want to call EMS, well, we're going to be on the phone with them for roughly 5 minutes to give them all the proper information that they need in order for them to make a decision regarding whether or not to dispatch the ambulance to the site or not. That's going to take them about 10 minutes to arrive. Again, this is very dependent upon location, whether it's rural, urban, suburban, the distance from the nearest hospital, etc. Once the ambulance gets there, they're going to be there for about 10 minutes before they decide what to do. 10 minutes back to the hospital, and they're going to spend 10 minutes at the hospital before any sort of cooling or treatment begins to happen. So if we just look at just this timeline, we're already at 45 minutes before the patient is even started to get cooled, which is problematic. And if we go back to our 600 ticks, we have 10 minutes to decide what we want to do and to initiate cooling on site to ensure that we have enough time to cool them down within 30 minutes. Well, what do we cool them with? What do we have at our disposal that's effective in cooling the body? Well, here's a figure here that shows a number of cooling modalities and the resulting cooling rate. And the one thing I do want to point out is that our optimal cooling rate is going to be about 0.15 degrees centigrade per minute. That's what we want to achieve, okay? And that's what that the red line in this figure, that's what that's depicting. Everything to the right of that red line is going to be our optimal form of cooling, and everything to the left of that red line is going to be suboptimal. Now, everything to the right of that red line, if you read the specifics, it's some type of whole body immersion in water or dowsing, etc. The difference here being different temperatures of water assessed, etc. Everything to the left of that figure could be a number of things. Ice packs in the major arteries. It could be a fan with water or misting fans for those who have access to a helicopter. We have a helicopter downdraft cooling rate here as well. So a number of things that we can have to cool the body, but not adequately. Now, if we want to kind of look at some more examples here, I have that here. And say we have a heat stroke patient come in and say that their initial rectal temperature is 108 degrees, which isn't uncommon. With my experience at Falmouth Road Race, most of the patients that I've treated in my career, on average, their rectal temperature is anywhere between 107 and 109 when they come to me to treat. So, starting at 108 is not not bad. And then you can see here, I have a number of different times and moments here. So if we look at the far right-hand part of the graph, and this is the study that has the study in scientific literature that has shown the highest cooling rate, 0.35 Celsius per minute. So super, super cold water. It's going to be about 10 minutes for them to go from 108 to 102. And 102 is going to be our threshold to stop cooling. Now remember, we're going to be taking temperature within their rectum, so it has to be pretty well insulated by the other internal organs. So if we stop cooling at 102, we know that you know, they're going to continue to cool down because their muscles and blood is actually colder than the rectum, and we're going to prevent them from becoming hypothermic and having to treat that medical condition as well. So cooling is going to go to 102 to ensure that we're well below the threshold for cell damage, which is around 105.5 degrees Fahrenheit, and well above the level for hypothermia. Now, if we look at just the level of the average cooling rate, right around 0.2 degrees Celsius per minute, it's going to take about 17 minutes to get from 108 to 102. And if we actually look at our ice packs and our major arteries, which is typically what's done, or the only thing available on the ambulance, we're looking at about an hour and a half to cool down those 6 degrees. Again, if we want to make sure that we cool down our patients within a 30-minute period, we need to have some type of whole body cold water immersion. And this figure is kind of depicting the same thing, where the gray box here is depicting that 30-minute window. That black horizontal line is depicting our the threshold for cell damage within our bodies, so the level at which our proteins and cells and tissues start to break down. And then the solid figures, the filled-in figures, or symbols, are going to be depicting some type of cold water immersion and those resulting cooling rates. And then the open circles are going to be depicting some inefficient means. And we can see that with our optimal scenario here, and say this is, you know, have an on-site medical provider, they collapse at the point where that arrow is. We take a rectal temperature, we cool them down. We can cool them down well within that 30-minute window, versus the situation on the far right where, say, there's an absence of care or they're not properly triaged. You know, we're way past that window, and the chance of catastrophic outcomes is much greater. So at the Falmouth Road Race, you know, we're connecting all these dots, at least the first three. They've done a pretty good job, and this is data from the 274 cases of exertional heat stroke, and they've had 100% survival. They recognize everyone that crosses that finish line that may be having a problem. They take a rectal temperature on those individuals. If they're above 104, everyone gets cooled in cold water immersion until they're 102, and then everyone goes home. They've been very successful in this management treatment for exertional heat stroke and whatnot. So again, 100%, that's pretty darn good. This is what it looks like at Falmouth. Again, we're outside. We're you know, right off the beach, and we just have a series of tubs. And you know, on average, we see 15 to 20 heat strokes a year. So we need a pretty large space that's capable of treating a large number of patients all at one time. So here's what that looks like, just for those who may be unfamiliar or have never had the opportunity to be able to volunteer their time at a mass participation event such as this. Again, here's just another scenario, same series of figures of how to, you know, put someone into a cooling tub. And in this figure, we have a nice porous stretcher that you can buy that is quite easy to be able to strap someone to, and use the straps to place them into a cooling tub there. So that's just another effective way of doing that. Here are some other pictures from the Falmouth Road Race of someone being treated. In this race, you know, the tubs are a little bit smaller, so we definitely maximize the cooling potential and have towels that we dip in ice water and cover any exposed extremities just to maximize the surface area being cooled, including their head, as you can see. And you can see the person on the right here. This person that's holding their rectal thermistor is quite happy because, if you can look closely, their rectal temperature is down below 40 Celsius. They're cooling down, and their life has been saved from this particular event that they succumb to. So what are some alternatives? So say we don't have access to a tub with ice and water. What else can we do to make sure that we have a proper or a sufficient cooling rate to cool our patients down? Well, we did a study a couple of years ago where we wanted to create a more portable cooling tub, if you will. And we used a tarp. We went to Home Depot, we bought a tarp, and then we used ice and water to fill it up and create a portable modified cold water immersion tub, if you will, where we have people holding the sides of the tarp up, and we're oscillating that water to cover the body surface area. And we're able to show that cooling rate was 0.17 degrees Celsius per minute, well above our optimal cooling threshold that we need to do that. Now, our last step to survival is our rapid advanced care. And in most settings, especially in our traditional settings, in our athletic setting, if we have a patient or an athlete that has an exertional heat stroke and they're treated on site, we need them to be transported to the nearest medical facility after they're cooled to make sure that the proper follow-up care occurs. And this is really related to making sure that the blood work is done, to look at a blood profile, and to document that, particularly for that individual's primary care physician to kind of help manage that or manage that recovery and have access to that physiological data going forward, which will then help with determining return to play scenarios. The other big thing, I want you all to be aware of is, since healthcare is really pretty much siloed, right? We have athletic training and EMS and PT and physicians and nurses and PAs. We all like to live in our silos, and I think that's an unfortunate thing. And hopefully, as we, continue to evolve in medicine and we see the value in interdisciplinary care, we kind of break down some of those silos to really advocate for more for the patient's care than anything. But this is really a good point to have the conversations with your local EMS or the people that would be responding to an emergency situation to make sure that they're on board. The worst thing that we need to have happen is to have a turf battle between the on-site medical provider, the athletic trainer, and EMS. Now, a perfect example will be that of Gavin Class, who was a football player at Towson. He had a heat stroke during a conditioning session. Luckily, the athletic trainer there at the time recognized that there was an issue in his collapse, threw him into a cold tub immediately because he suspected an exertional heat stroke. They called EMS, which was great. EMS came. They demanded that he be removed from the cooling tub. Unfortunately, the athletic trainer never took Gavin's rectal temperature, so there was no objective measurement to keep Gavin in the tub. In that case, EMS removed him, got to the hospital. He was over 106, still 90 minutes later, 14 surgeries later. He luckily recovered. He lived, but he was never able ever to play football again. Using some examples, and that is a really good example in that case to show, if there was coordinated care between the different entities responding to the emergency, the care may have been maximized. So being able to have those conversations, having your annual trainings with EMS to make sure that part of that training encompasses heat stroke care is going to be vital. But why does this matter? And I have a couple of examples here. So we have a middle-aged male running in a summertime road race. He finishes a road race and he starts kind of acting all out of sorts, running, he's yelling at people. A police officer noticed this, went up to the runner. The runner tried to punch the police officer in the face, which is always a very, very bad idea. Never try to punch a police officer in the face. Luckily, one of the medical volunteers saw this happen, thought to themselves, hey, this might be a heat stroke patient, ran over, convinced the police officer to, hey, let's bring him to the medical tent. His temperature was over 107. They cooled him down, saved his life. the situation was explained to the police officer, and luckily the individual was never arrested. The police officer understood the medical emergency that was that the person was facing. Now here's a more unfortunate situation. An 18-year-old freshman baseball player is practicing, and they were in their 4th hour of practice, which blows my mind as far as why college baseball players need to practice for 4 hours, but it is what it is. Collapsed. There wasn't an athletic trainer there at the site at the baseball practice. The coach initially applied wet towels and called 911. During transport, the individual became combative, tried to escape from the ambulance. Protocol was to stop the ambulance to restrain the patient until police backup arrived, delaying transport even further. And then he had to end up being transported to a higher level care facility, and he was never able to fully recover there. So again, this just goes to show that immediate on-site treatment is going to be vital for this case. Now let's talk about recovery real briefly. And exertional heat stroke recovery, this is probably the biggest area in research that needs to be further investigated. Most of the evidence revolving return to play or the recovery of exertional heat stroke is based on case studies, case series, expert opinion, or anecdotal reports. There's really not solid evidence-based medicine or research to really support the steps here, but this is the best that we have here. And the biggest things here really to one, identify what caused the heat stroke, because once you figure out what caused the heat stroke, you can then move forward to help prevent that from occurring again in the future, okay? But from our return to play guidelines, we have a set of guidelines that is really, again, guided based on anecdotal expert opinion. But the basic structure is to be similar to a graded return to play protocol. For the first week, nothing is going to occur, no exercise. This is going to allow the tissues, the affected tissues and organs to heal. And then once cleared by the physician, once their lab work becomes normal, return to a slow progression of exercise, starting in a cooler environment, building up the duration, intensity, volume, and then slowly working in the heat exposure to really kind of help reestablish that thermal tolerance. But what if? And the last few slides here for this talk is the but what if. And this is really to help address any of the questions that you all may have, because these are the questions I get every time I give this talk. But what if? What if I'm an athletic trainer and my administrator won't let me use a rectal thermometer? Or what if I don't want to use a rectal thermometer because my athletes are minors? So if you say you're in a youth or high school setting. Or I'm worried about a privacy issue or exposing my athlete. Other questions, EMS wants to take my athlete as soon as they arrive, or I don't have access to a cold tub. So we can probably have, at least 75 other questions that we could probably come up with if we had the time to think about it. But what if? What if all these situations happen? Well, let's briefly talk about the legal aspects of things and why this is important. Well, if we look at just the standard of care in athletic training, and by definition, this is going to be the legal duty to provide healthcare services consistent with what other healthcare practitioners of the same training, education, and credentialing would provide under similar circumstances. That's what we as athletic trainers are required to do, to practice in our profession, is to do things that are consistent with our training and our education and our credentialing, okay? Now we can talk about negligence here, and here is just the Google definition of negligence and the failure to take proper care in doing something. I'm not going to belabor that point at all. But going back to our but what if questions and all that. Well, what standards do we follow? Luckily, in sports medicine and medicine, we have a large number of resources that we have at our disposal that are consensus and position statements and inter-association task force statements, etc., that we can use to justify our approach. So say we have an administrator that's not letting us do what we should have, or not letting us have procedures in place that should be provided. We can provide that administrator these resources outlining the proper steps that are needed to properly properly care for this condition. So we can use this as a really good tool as providers to advocate for the best care for our patients, whether it be with our administrators, whether it be with our, the PTOs, or, you name it. We can use these documents to our advantage. Now there's a flip side to this, because if we are practicing and if we have a patient that has a heat stroke and they're not properly managed, you better believe that with the ensuing lawsuit that will occur, because most likely there would be a lawsuit that occurs, and with any lapse in care that may be evident, anyone that's involved in that situation, including the athletic trainer or the administrator or the school or the athletics association, or you name it, they're going to be named in that lawsuit. And I would hate to be the provider that failed to act, and they're on the witness stand in the trial, and the prosecuting attorney comes up and lays down each of these documents in front of the athletic trainer and asks why they didn't follow the standards of care. I would hate to be in that position myself. So yeah, there's a really good side of having all this evidence, but there's also a very bad side. So we need to do our best to make sure that we are properly educated and trained and know what to do and how to properly care for our patients. So our kind of main takeaway is, we cannot prevent heat stroke from occurring. However, if we follow our 4 outlined steps that I provided thus far, we can make sure that we do a pretty good job of ensuring survival. And really, we need a coordinated care, coordinated effort between all aspects of medical care and healthcare that would be responding or caring for this situation to really ensure and optimize our patients' outcomes. I want to thank you all for your time and listening to this presentation. If there's any other questions or follow-up, please feel free to shoot me an email. Here's my email address, and we can go from there. Again, thank you very much, and enjoy.